Good afternoon. And today we have a pleasure of interviewing orthodontist Dr. Marisa Santos from Buenos Aires, Argentina. She joined us for Argentina. Good afternoon, doctor.
Good afternoon.
And thank you very much to our audience. If you have trouble sleeping or sleep next to snoring partner, this program is going to be for you because you're going to be able to connect the roots of that sleeping problem in the facial development, the topic we talk a lot on this channel. And if you're a medical professional who, just like us, me and Marisa, trying to put all puzzle of facial development and sleep apnea or sleep problems of the modern age together, this program is going to be for you. We're going to talk a little bit about historical parts of that development and how professionals, not just in the United States, but all around the world, wake up. Just I call it breathless awakening, topic of my book or title of my book, wake up and changing the philosophy, how they treat kids. Treat them early, treat them later. We're going to talk about that today. But I'm going to first introduce my guest, why I brought her on the channel. We met on a mewing conference in London where I present, and she was also one of the presenters, and I really was impressed with her approach because she was able to put together dream for a lot of practitioners, medical part and orthodontic part, I would say, under one roof. She's a teacher, she's a professor in a university in Buenos Aires, and she teaches in orthodontic department. She also has her own courses, and some of the courses you can actually register online visiting her website. You'll find the link underneath this interview. And also she worked or founded of 3 orthodontic offices. So my question to you, Marisa, I'm sure your education was a standard orthodontic education. So tell me, what happened? How you changed the course of whatever, you were brought up in your orthodontic training?
Well, hello. Well, many things changed. The first one was that my little girl, my third girl, was inverted white, and I said won't wait till 7, and this can't be genetics. So that was my first question. Then I work in a pediatric center with 35 professionals, so I'm not alone in my consultation. And well, so I have a lot of doubts being an orthodontic because I treat little kids, and I said, but I can't wait till 7 till 6 to correct this.
Until 13?
No. That this is crazy. This is crazy. So that was my I had a lot of questions when I'm 10 years being an orthodontics. And well, then someone gave me a link that I went with John Mew. I helped in the translation of his book, and his philosophy changed everything. Forward growth, chewing, breathing through the nose, a tropic premise. So, he was a philosopher. I don't know if he was an orthodontic, but he was a philosopher. And so the 2 last events, I was with John. I told him, I put everything, but in a 3 years old. I start treatments at the age of 3. 3 years old, orthopedic treatment.
I have a question. Why? Why you start in the age 3? What's so special about this particular age, and what changed after that? Before, after age of 6, what changed? Why treatment should happen?
Sutures change. No, here I have the sutures. We don't have sutures when we are 8 or 9. Now with tomography at university, we understand. So we grow, especially until the age of 6. So why do we treat at the age of 8? I have no idea. No really idea. We have to work with a kid when we need the maxilla, not for alignment of teeth. We need the maxilla to breathe, to talk, to swallow. So we need that boy to be good before he starts scholarship. That's why we treat at 3.
I have a question for you. Like a lot of orthodontists don't start in the age of 3 because of the behavioral, they find it difficult to manage kids in the age of 3. Tell us, what orthodontic strategies you use for somebody who is?
There's no orthodontic strategy for the kids. This is a medical treatment. So the treatment is for the parents. They have to understand that you want them to breathe, you want them to chew, they want them to talk properly. So I don't have problems with the kids. Parents have to understand that this is a must. You have to do it. This is because the orthodontic will be better also, but this is something that we need for your boy to breathe. Breathe, chew, swallow, talk. How can we treat that at 7? Why do we leave a kid in kindergarten with like this, going to the myofunctional therapist, saying the R? No, 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 no. So, where do we grow? Until 6. So that's why I treat before 6.
That's very nice. So you use traditional expanders for little kids,
No,
or
no,
you
no, no
use.
traditionals. No, no. I have my own expanders.
Can you talk about what you learned from Dr. John Liu, but apply in your own terms?
Well, my appliances are my appliances. I keep on changing appliances because everyone has to understand that kids are worse, 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 and worse. We now find kids of 4 years old that have crowded, deciduous teeth. So imagine what will be that orthodontic at the age of 8. So I
It's
keep
gonna be extraction.
no, well, that's why I can't believe that we, in my age, orthodontics of my generation, are being taught, well, teeth, we don't have space. So we take out 4 premolars. I can't believe this. I really don't believe this. And so I believe in expansion, forward growth, chewing, breathing through the nose, the tropic premise. So I can't believe what's happening, but I have a gift. I'm a teacher at university. So my magister, I'm there teaching orthodontists. So things will be changing in some years because we can't make those difficult orthodontics. My friends they do incredible orthodontics with mini plates and screw, but if you have the first faces at the age of 3 or 4 and then a second one at the age of 5.5 or 6, then you have another kid and the orthodontic will be very simple. So it's so easy, my protocol, so easy.
Can
I've
you talk
never,
about your protocol with us?
it's very simple. My protocol, this protocol, and my functional therapist gave me this protocol in Rome many years ago, and I changed that protocol. So it's divided in 3. First, the diagnosis phase, where we have the ENT with adenoids, tonsils, nostrils, lingual frenulum, and all that. Then the orthodontic, that is the one that changed the bone of the maxilla, the first part of the airway. We are the responsible of changing this. And then my functional therapist with the Ablock maneuver of Wilfred Engelke. We every kid finishes like that. Ideally, starting with all these things at 3, with the ENT, the lingual, if they have to go to do surgery, and that is 4 is the best age to treat kids. 5, yes. Then when they are 6, we have teeth growing there, and so then we have to start changing things because we run and with the teeth there, so it's difficult. And at this moment, 2025, the worst thing that can happen to an orthodontic is a child of 8, 9, and 10, because it's not for the early treatment, and it's not for the other treatment. And so we have today, I spoke with a friend of mine at the university. What can we do with these kids of 8 that they have no canines, no space? So it's very difficult. So when you get space at the age of 4, you have another kid. And so it's incredible the changes that you get with this protocol. Incredible.
I have a question. What's your preference? Fixed appliance or removable appliance?
I don't use removable. I use fixed appliance at these ages because we measure with Reno Devito manometry the airflow, and the only appliance that showed changes before and after this junction, no expansion, non-dental alveolar, the suture is the fixed appliance with a specific protocol for each kid. 2 turns, rapid, semi-rapid, that is for every kid. We have an exactly protocol, but I work in sutures, not in the lower, of course not. In the lower, we don't have suture, but I work with sutures, yes.
But my question to you, what do you do with the lower in this case? Because if lower doesn't have a suture, how
Well,
you teach what the bite gonna be coordinated?
I expand with stage 1 BioBlock Orthotropics. The stage 1, it's an appliance that it's not like a Schwartz. No, we have it 24 hours a day. They have to chew with the appliance or fixed expansor, but we know that we are expanding dental alveolar in the lower. No, but we first at this age treat craniofacial anomalies. We are not treating malocclusion. Malocclusion is like saying, I have fever. It's something that a dentist, a pediatric dentist, has to see and said, oh, this kid has something else. This kid, so I have to refer him to an orthodontic. And here is the problem, no? Pediatric dentists, as orthodontics, don't treat kids of 3, 4, and 5. Pediatric dentists are starting to treat them. I for all the years I have teaching, that orthodontics has to do this because we have another training and we know things that pediatric dentists do not. So I think that you have to be an orthodontic to do this. And you don't need any, like playing with a kid and no. Parents, this is medical. You have to give this vaccine. You have to do it. Okay? No choice. So the third consultation is with the parents. It will not hurt. This will not hurt. This is very, very, very fabulous for your kid, for breathing. I use face mask in almost every case for forward growth. So, but when everyone do the treatment, I have no problem with patients.
That's beautiful. You use the face mask and you say it like that, like, okay.
Yes. I'm almost 25 years doing this, but 15 years improving the protocol. And we're going all around the world doing this. So many people are doing this here in Latin America. It's not like in Europe. It's not like in the United States. In the United States, there are more pediatric dentists doing this. But here in Latin America, I go to somewhere and in 3 hours, no space for more. So this is the future in orthodontics.
That's nice to hear. That means, I'm treating adults, I treat sleep apnea. So hopefully, when the future become present, with a sleep dentist or, dental sleep medicine would not have that many patients. So I really have a lot of hope for that.
Better patients, because when you have a patient with a good maxilla, it's very different than having a patient with a maxilla like this that has to go to MARPE or skeletal appliances or surgery and all that thing. You have to do it, but it's difficult to do it. So when you have a grown-up people with a good maxilla, you have less problems.
Of
It's
course.
more easy fixing that patient.
Of course, because the nose has totally different resistance. Doesn't have like resistance, like no air gonna come here. Of course. My question to you, I want to ask you, like original question. We met at the Mewing conference, and I know you are big, you are really devoted to the memory of John Mew, and you gonna have a congress kind of bringing the principles or his ideas, his philosophical ideas, into life, I would put it. So can you tell us about that Congress? Who did you invite as speakers? And what would be your vision for the audience, people who will go to beautiful Buenos Aires and learn so much?
Well, it's not my symposium, is the International Association of Facial Growth Guidance. It's the 20th symposium. So 30 years making this symposium. It started with John, and last year in Seoul, he told me, Marisa, you will do it in Buenos Aires, because it never we held the symposium there in Latin America, and I will be alive or dead. So, but you will do it. So, but I told him I will do it, but not for the orthotropic people that are like a kind of. I will open that to early treatment. You know what I do, John? I never lie. I said exactly what I do to ENTs, pediatricians. The keynote speaker is a pediatrician, not a pediatric dentist, Maria Piabella, specialist in airway. So, you know, pediatricians, ENTs coming from all around the world, orthodontics, myofunctional therapists, physiotherapists. So open the game for everyone to come. The myofunctional therapist will do a kind of workshop. The ENT want to do that. Yes, for everyone. It's not my symposium.
Yeah, no, but you actively, at least in a symposium where we were together, you were the leader of your symposium.
Yes,
That's why I said,
I'm the leader because John asked me. I think that he was such a brilliant man. But I told him that I will do everything, but inside the profession, not fighting, inside the profession, teaching inside the orthodontic community, because I love orthodontics like a medical specialization, not aesthetics. So, and I'm doing that. I'm inside university teaching orthodontics to treat a little kid inside a transdisciplinary protocol for many years. So I think that I did what I promised I will do. So many years I went to study to London. So I think that will change. It will be a game changer. And now I understand why it's Argentina, why it's Buenos Aires, why he choose, because he's so brilliant man, why he choose this country and me.
why?
You know, because many people here in Latin America are doing this. It's not like what I saw in London, for example. We are open-minded, but Argentina is like the Switzerland of Latin America.
I
It's
know, I love Argentina.
well, it's not like we are doing anything. No. This is the ENT, this is the orthodontic, and this is a myofunctional therapist. So it will be a game changer.
I really hope so. And we're going to put the link underneath this interview. So people who are interested, they will be able to get in touch, with your administrative, assistants, whatever, and become part of that life, whatever, game time changing moment. So that's very promising. And I also, my last question to you would be that transdisciplinary approach, because in a way I'm asking it in a under very special light. It's, in United States, orthodontist is isolated profession. You practice in your little shop, you build your little practice, you have your assistants around you, but, the orthodontist is alone. I know on a Congress, when I was on the UN conference, you talk about transdisciplinary team. And for a lot of people who listening to this channel, and, in my community, or, people who in my other community who gonna, who supported me already with my book, they all dreaming about this transdisciplinary approach when medicine and dentistry somehow united. Because for parents to make a decision and to go with the treatment when child is 3, it's much easier when not one doctor say that, but medical doctor, pediatrician, ENT on the same page, and they talking about the child future. So from that standpoint, how you synchronize pediatrician, ENT, ortho, all of that?
Well, I'm here in a pediatric center, and that is like, we can say, well, I don't know why, I'm here, and I know, and I always worked with this transdisciplinary team. And then in Buenos Aires, I also work with ENT, pediatrician, and mass. As I think that the first thing that you have to do is to take a coffee with the ENT of your city, because if not, things won't be okay. The easy part of the treatment is putting an appliance and turning a screw. It will turn. But then why that will be remain like that? If you don't have a good airway, if you don't have a good myofunctional therapist, and the kid starts breathing through the nose, chewing and making all this, you will fail. You will fail. It's like the orthodontics. Someone puts your teeth like this, and then the teeth crowded again. So you need those things. So you have to work with them. And also telling the myofunctional therapist that they have to work with an orthodontic, because sometimes there are 3 years going to a myofunctional therapy with a padded like this. So it's for everyone, the transdisciplinary protocol. And the ENTs know that we need to change this maxilla to breathe. We help kids, and they know that. So that is transdisciplinary. And I work with I'm invited to many congresses of ENTs, myofunctional therapists. Well, it is a life. For me, it's a life. I think that for my pupils would be easier, or this will be like a normal standard of care. No, I think that something has to change there in the AAO.
No.
Yes, because many years I sent everything. I want to talk there with all my curricula, and they said, no, we are not interested. So we have to change the AAO. Orthodontics have to start early, because what they say, I don't know who, well, we have to start at 7, an early consultation. It was many years ago, and things change, and kids change, we change, the society change. So we have to.
You actually, my last question. You are actually practicing, I don't know, 30 years, 25 years in this field, 25 years. You notice what the jaw actually.
Yes, please. I never saw in my life a 4 years old with crowded deciduous teeth, you know, and the airway with like this, that you have to refer to the ENT at the very minute. I never saw this in my entire life. No, 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 no. We have problems with the canines. That's why I describe the modern kid. Well, the canines of something, but not what we are seeing now. This is crazy. So we have to understand.
some.
There are many, there are books, there are scientific articles saying this, anthropologists saying this, and we still saying, no, we have to extract. No, please, no, no, no.
Thank you very much, Dr. Santos, and I highly recommend people who listening to this interview take a look at Dr. Marisa Santos' website. You're gonna find the link underneath, and join her on a congress in beautiful Buenos Aires and learn about early orthodontic treatment in the age. Thank you.
Bye.